Hello, ladies and gentlemen. Nice to see you here. And if we have audio issues, please let me know. If not, let's continue with our today's topic. Possibly you also have questions related to our yesterday's topic. If you do, please also tell me. And today we must finish our sensory motor complex topic group, and we will focus on basal ganglia, cerebellum, and their tracts, their fibers, and their participation in motor acts. So let's begin, and I'll switch to the presentation in a moment. Here we go. By the way, what you see on the screen is an enlarged and colorized electronic microscopy of rat's Purkinje cells. They are clearly visible as separate cell bodies, and they are extremely large in comparison to other neurons. So under proper software correction, you may see that this makes beautiful pictures. And by the way, it's also clearly visible that the outermost layer here is nearly cell-free because these are axons. So let's start studying it all. First of all, the term basal ganglia itself, it's not very correct term, and in modern literature you may frequently find term basal nuclei. You should blame early anatomists because basal ganglia, any ganglia is a collection of neurons outside CNS, and basal nuclei is probably a more correct term, but basal ganglia is a historic term. Actually, both basal ganglia and cerebellum do the same job, but from different sides. They correct movement on a real-time basis. They apply agitatory and suppressory activities, and if there is a motor plan born in frontal cortex and its completion has begun, basal ganglia may slow down its completion and cerebellum may speed up. On the other hand, cerebellum additionally participates in ocular motion tasks and in motor learning process, and motor cortex sends sorts of carbon copies of motor acts to both the basal ganglia and cerebellum, and both structures, after integration with other sensory information, return the output back to cortex. They are not in opposition, they are in smooth balance, and once there is a disturbance in this balance, conditions arrive that we call movement disorders, and disturbances in these systems produces movement disorder symptoms. Let's look at the motor hierarchy altogether. We already studied pyramidal pathway and sensory tracts, so we know that everything begins in the premotor cortex. On the subliminal level, once it is born, it is carried to execution to lower segmental portions of pyramidal tract through the brainstem, and then to the spinal cord, lower motor neurons. At the same time, as far as we know, basal ganglia and cerebellum receive association fibers, and these are these carbon copies I was talking about. Additionally, they receive somatic sensory proprioceptive inputs from the non-crossing deep sensory pathway, and after integration is born, after integration is processed in the basal nuclei, their output is returned back to the cortex, and we are able to adjust our motor activity. A reminder from your anatomy course, and there are various ways to group these nuclei, and we may include caudate, putamen, nucleus accumbens, globus pallidus, substantia nigra, subthalamic nucleus, and we may produce groupings like claustrum or amygdala. Actually, these historical groupings are useless in clinical approach when we look at their functional connection. Here we move further from topography. We are more focused on interactions, and we see that caudate and putamen are the doorway to basal ganglia, and this is the initial point of the cortex motor input. These caudate and putamen have multiple interactions, bidirectional interactions with substantia nigra, for example, which is famous for its pigmented neurons producing dopamine, and extinction of these neurons produces Parkinson's disease. Output is also performed to two portions of globus pallidus, external and internal. On its side, globus pallidus also interacts with subthalamic nucleus, responsible for ocular motion, and finally produces output to thalamus, and then to the cortex. This looks sophisticated, but it will get even more interesting when we look at the biochemical interaction. And we know that nervous system frequently uses acetylcholine, but here we see three neurotransmitters involved. There is a big array, and many synapses are not just excitatory, there are many inhibitory. For example, synapse between caudate nucleus and putamen and substantia nigra is of inhibitory type, and it uses gamma aminobutter, and output of substantia nigra is also inhibitory, and it uses dopamine, and if it disappears, then there is insufficient suppression of acetylcholine output from caudate nucleus and putamen. There are multiple ways to fix this, and this is a story for the next year. We will speak about only Parkinsonism today, but not Parkinson's disease. But just to say a few words, we can produce either supplement with dopamine precursors or perform deep brain stimulation with electric implants like cardiac drivers. So what we see next? The next synapse is excitatory. It is acetylcholine, and the synapse from globus pallidus to thalamus is inhibitory again. So you see polarity changes a lot of times, and this will get important when we speak about the lesions of the basal ganglia, because signal will switch from inhibitory to excitatory several times. First example, Parkinson's disease we see, or Parkinsonism, and Parkinsonism clinically is manifested by a triad of symptoms, all associated with insufficient movement, insufficient motor activity, because it's over-suppressed by thalamic output, in fact. And we know that all Parkinsonism patients are very limited in their motion. It is a great and big effort for them to make a first step. And once they start stepping, their steps are small, their muscles are rigid, and this is a very typical Parkinson's paralysis with a rigid cogwheel phenomenon, muscle tone. When we try to flex an extremity, it moves in sort of small increments. Very typical and the hallmark sign of Parkinsonism is rest tremor, and this is a very specific tremor with oscillations of around 3-5 hertz frequency and about 5-6-7 centimeters amplitude, and a very specific rolling pattern, or as it was called, P rolling pattern. If you look closer at a Parkinsonism patient, you will see that the patient makes a sort of rolling movement. And if someone has subscribed to Telegram, I have posted a video of Parkinson's patient examination. And if you look to the Telegram, one of the latest posts was this Parkinsonism examination examples, which I really suggest you to watch. Another example here, and by the way, why it happens in biochemical approach, we see that substantia nigra doesn't produce enough inhibition to acetylcholine synapse, and it becomes overactive. It's not suppressed by substantia nigra synapse, which is inhibitory sort. And other result, this synapse, which is inhibitory, is overstimulated, and it starts suppressing the motor cortex. And the contrary happens in conditions like chorea. We see that here this synapse is preserved, and it suppresses this acetylcholine portion too much, and this suppression is insufficient, and as a result patient gets involuntary movement, or what we call hyperkinesis. There are many other options for damage to this system. For example, if globus pallidus is being damaged, like in boxers, maybe you remember Muhammad Ali, famous boxer, and for some reason they showed his MRI on TV, and I clearly recognized globus pallidus lesion after constant beating to his head, and he developed severe post-traumatic Parkinsonism. And similar events are possible on vascular basis, and there is a big group of vascular Parkinsonism conditions. And finally, drug-induced Parkinsonisms also, because for many psychiatric conditions, for example, there are antipsychotic drugs which are given to stabilize patients' mood and behavior. And as a side effect, they are strong suppressors of dopamine synapse. And after 3 weeks course of such psychotropical drugs, patients may develop severe Parkinsonism. And if it is continued over 6 months, then there is a risk of constant damage to dopamine synapse. Modern antipsychotics are not so dangerous, but some old timers which are still approved may produce this sort of event. Subcortical lesions of CNS are rather frequent story, post-traumatic, oncologic, post-infectious, and we can name a lot of stroke subtypes, but this will be the story for the next year. And another half of this subcortical motor control subsystem is cerebellum. And cerebellum in Latin is small brain. This is a good name because actually it is really very similar on macroscopic level. It has its own deep nuclei. It has its cortex. It is similar macroscopically, but it is very different on its topographic and tract basis. It first of all, it works on ipsilateral basis. It doesn't support this doesn't support this concept of crossing pathways. Just to remind, I believe you remember it all, because you have had it only 2 years ago. These are cerebellar divisions. We can remember spina cerebellum, which includes vermis and intermediate portion, responsible for the limbs and trunk. Cerebellum, lateral hemispheres, is this motor processing and motor learning, and additionally there is a floccular nodular lobe responsible for ocular control. Cerebellum is subject not only to localized damage, it is sensitive to trophic factors, for example poisoning, and it is very sensitive to alcohol poisoning. Every one of us unfortunately has seen a drunk subject, and chronic alcoholic subjects develop cortical lesions, and their cortex of the cerebellum doesn't look so dense and rich. It looks dystrophic, and the spaces between the foli of cerebellum are much bigger. Another problem for cerebellar lesion is craniovertebral anomaly, so tight or insufficient space in posterior fossa. This is recently has been proven to be genetically based, and in this case it develops with age. Cerebellum is strictly limited with the tentorium from the top and the rigid skull from the bottom, and once there is a compression, both cerebellum and brainstem are suffering structures. By 25 years you develop a very rigid skull, and if this is a limited space, then patients develop generalized cerebellar syndromes like vertigo, first of all, diplopia, double vision, slurred speech, and additional trouble for them is that the flow of cerebrospinal fluid from the ventricles, which goes through the aqueduct, changes its pressure gradient, and patients develop vertebral problems. First of all, formation of cavities in spinal cord. This is an associated condition called syringomyelia. So this is a structure which looks relatively simple in comparison to big brain neocortex structures, but it has very tricky diagnostics sometimes. Let's look at the tracts in the cerebellum, and we see that here it's easy to operate number 3 because everything comes in triple. There are 3 incoming highways in 3 incoming tracts, 3 outgoing tracts, 3 deep nuclei, 3 peduncles. So this is possibly the only thing that makes remembering easier. 3 inputs are, first of all, mossy fibers from spinous cerebellar pathways. You remember the spinous cerebellar pathway, which we studied yesterday. Climbing fibers from the inferior olive, and additional mossy fibers from the pons, which deliver cerebral cortex output. And finally, there are 3 deep nuclei, fastigial, interposed, and dentate. Another difficulty with cerebellum is a great variety of cell types. In fact, only Purkinje neurons are doing the job. They are processors, and they produce the final output of the cerebellum, while the others are mainly serving connection framework, and they are mainly expanding dendrites to interconnect cells in between, but they all are needed. They are granule neurons, stellate neurons, basket neurons, and Golgi neurons. They are all located in various layers of cerebellar cortex, and only now we can enlarge a single cerebellar cortex, and let's have a look how it looks like if we make it bigger. So first of all, on the bottom of the image you see the inputs. There are 2 sources of mossy fibers and climbing fibers, And we see that there are multiple layers. The outermost layer of the cerebellar cortex is called molecular layer. First of all, because it is nearly cell-free. Instead, it is occupied by axons and dendrites mostly. And the layer below is a monolayer of large cells called Purkinje cells. They are the central layers in the circuitry of cerebellum. And below the Purkinje cells, it's a dense layers of tiny neurons called granule cells. And in the center of the folia is a white matter with all axons traveling in and out. And the first option you see, mossy fibers connecting not right to Purkinje neurons. They instead connect to granule cell layer neurons, and each granule cell expands several dendrites which grab lots of mossy fibers. So in fact there are tens and hundreds, and its outgoing axon is going through the Purkinje cell layers and runs parallel to the surface. It is called parallel fiber. You see this T-shaped connection and multiple parallel fibers running on the top, and only on this level Purkinje cell expands its dendrites to grab parallel fibers. Surprisingly, Purkinje cells looks like a two-dimensional structure. It looks all of these multiple outgoing dendrites are located in the same plane, and if you look from the top, from here, it may look expensive, as it is an expansive tree. If we look from a side, we see that all of these axons are lying in the same plane, like on a sheet of paper. And finally, output goes to deep nuclei. This is not the only option. So we see there are, in this scheme, multiple hundreds of mossy fibers are needed to activate a single Purkinje cell neurons. And there is another option for climbing fibers. And in this case, all this preliminary circuitry is ignored, and there is a direct interaction with Purkinje cell dendrites. In several cases, options exist. For example, Golgi cell, which returns the input from mossy fibers to parallel fibers. It's an interneuron, or a basket cell also acting as an interneuron, or a stellate cell. They are all acting as an interneuron to interconnect participants of the scheme. This is electronic microscopy, and we see that, for example, basket cell on the bottom part of the image drops axon branches down to the Purkinje cell layer, and there the branches wrap around cell bodies like baskets. And Purkinje cells, as I have taught, compare and process varying inputs it gets, and finally sends its own axons out through the white matter and down to the deep nuclei. This is all concerning the topography. We need to speak about clinical aspects. As I have told, there is a video available, but just in case somebody doesn't have Telegram, I will post a direct link here in the chat room, so you will be able to have a look. And this really takes a couple of seconds, but we need it to continue. So pay attention to the chat room. By the way, only 8 participants, what I have noticed now. This is to me it seems much less than actually should be. Possibly someone is on YouTube, I don't know. But actually here in Zoom we do the accounting, and I really suggest you to attend, because missing students are clearly seen here. I have the journal right under my hand, and even remote sessions should not be missed. This is something that is being controlled even for me, and we will have to submit. If you miss more than 3 classes, then you will have to reattend. So, cerebellar dysfunction, this complex is called ataxia. This is a complex of symptoms, and they all are generally involving lack of coordination. And it may be either localized or generalized. If we deal with regular dysfunction like vascular or toxic like alcoholic, then it's pretty generalized. If you have seen a chronic alcoholic, you have noticed that he or she is walking like being drunk already without consumption, and generalized discoordination is easily noticed on patient's gait. This is a very typical broad-based gait. It's indicative of ataxia. There are finger pointing tests like finger to nose test and ankle to knee test. And in the educational video for motor system, which I was distributing before, you will see that how these tests are being performed. Structural abnormalities of the cerebellum also include neoplasms, but I would say that they are very frequent in pediatric courses in pediatry, and this is every pediatrician will tell you that brain oncology in pediatrics is mainly posterior fossa. Hemorrhage and infarction are strokes, but traumatic hematomas are also possible. In every case, cerebellum suffers greatly from its limited and rigid space, and it is frequently accompanied with brainstem symptomatics. Frequently we use magnetic resonance imaging, first of all because computed tomography has limitations of technology, and just by technology posterior fossa is improportional on CT reconstruction, while magnetic resonance does a better job and it has better sensitivity and specificity. Also on magnetic resonance imaging we can make better measurements, and here a good quantitative measurement will be level of protrusion of cerebral tonsils to foramen magnum. And if we see that cerebral tonsils are protruding, if they get more than 3 millimeters below, then patient will with high probability will have cerebellar symptomatics. And finally, the one of the symptoms which was not listed here is nystagmus, and nystagmus is eyeball motion of repetitive up-down or left-right or rotatory jerking of eyeball when tracking objects. If we if we ask a patient with cerebellar involvement to track some object, we will see that in the outermost, in the lateralized or medialized location of eyeballs, there will be this rotatory jerking or nystagmus. And there are even instrumental diagnostics like Frenzel glasses, which will help you to localize, to measure this level. And additionally, I will drop you a very good video on examination of nystagmus and which sort of symptom is this, and how to measure this. And this will be also here in the chat room. Okay, here we go. And now, please pay attention to the chat room. Here, this link on nystagmus. Actually, it's a big topic of clinical neurology because nystagmus may be also different for peripheral lesions like benign positional vertigo or for middle ear semicircular channel pathology, and that is called peripheral nystagmus. And if patient comes to you with complaints for severe, for example, headache plus vertigo and disequilibrium, then you may perform assessment of nystagmus and perform differential diagnostics, and depending on the conditions when nystagmus arrives or disappears, you'll be able to decide if it is stroke in the cerebellum, or on the other hand, if it is purely peripheral lesion like semicircular channel otolites. So we are done for today, it looks to me. I only have to make an announcement that tomorrow I have night shift, and everyone who wants may call me. Everyone has my phone number, I believe, for some reason. If somebody doesn't, you may just message me in anywhere, I think, Telegram, WhatsApp. And the only limitation I can take is 4 students simultaneously, so you can share my time, but this will be 24-hour shift, and everyone who arrived was quite happy with that because it's real life. Do you have any questions related to... Yes. No, actually, for example, on 13th, it will be overnight shift on Wednesday. But this will be from 4 p.m. This will start from 4 p.m. until morning, and weekend is a 24-hour shift thing. So it's different. And those who arrive are forgiven their missed classes, of course. I have to produce some other sort of attraction. And because I see students are missing. Some students are missing. There are more than 8 definitely in the group. I have never seen just 10, but somebody's missing anyway. I'll check my list, which I have, and I'll compare those who are here in the room, and this will be our meeting journal. Please don't miss classes. Actually, I see students who have missed classes, and they always regret, because dean produces a lot of troubles for them. I don't, but the dean does, and I suggest it's always easier to have it's always easier to live with good karma. All right, then I think that I should say thank you for coming, for those who are here, and I should say goodbye. Thanks for attending. If you have questions, I will be happy to answer, but I see no questions yet. Thanks. Goodbye. And we should shut